All right, the record button is on. Ruth, you're on stage.
Okay, good morning. Welcome to Friday Chalk Talk. My name is Ruth Payne, and I am a chaplain with the Advocate Aurora Metro Milwaukee Hospitals, and I will be your moderator. Today we have a trio of presenters who will each speak to us about how they work in different ways to help give patients a voice. Chaplain Roberto Cortez will speak about how a chaplain's primary action is that of listening, and in doing so, advocating for patients, at times being their voice. He will share with us how the listening that chaplains do differs from other helping professions. Many of us who know Roberto know that he is from Mexico, but what most of us may not know until now is that his full name is Roberto Cortez Alemán, which means Roberto Cortez the German. Representing social work is our palliative care social worker, Kryn Kramer. Kryn will share with us a personal experience with a near centenarian and how honoring her voice affected her family, her friends, and the medical team. And what you might not yet know until now about Kryn is that she also doubles as Cupid. 25 years ago, while in college, Kryn worked for a video dating service and helped connect couples who eventually married. Physician Martin Mobazelak will take us down a very different road by sharing with us why too much patient autonomy can be harmful to our colleagues. Dr. Mobazelak's favorite introverted pastime is reading murder mysteries. And he says, quote, "I see a lot of similarities between Sherlock Holmes and the palliative medicine team when they navigate landmine fields and work to get to the truth while completing hospital consults." Our format today has 4 parts. The first 3 will be a 5-minute presentation from each person. And the last part, we will open up for discussion and questions. And with that, I give you our trio of presenters, beginning with the German.
Thank you, Rudy. Listening, I could never forget a lesson on listening that I learned several years ago at a code for a Spanish-speaking patient. One of the chaplain interns, Sam, who is now a chaplain in Grafton, I believe, chaplain intern Sam was shadowing me. I don't like shadowing. But, and especially for this one, because Spanish-speaking patient, oh man, Sam is gonna slow me down. And so, well, we got to the place, and when we got there, this lots of people, and while the patient was receiving CPR in the room, here are 2 nurses trying to help this woman. And when they saw me, I could see their faces saying, "Oh, finally, someone who can understand and communicate with her." Sam and I began to attend to this woman, and I was doing the talking because, of course, I am the Spanish-speaking chaplain. And the woman had a cell phone in her hands, and she was frustrated, but I continued talking and just trying to find out what her need was. And the more I talked, the more frustrated she became. And Sam, meanwhile, he was quiet and silent and just observing. And very kindly, he said to me, "Roberto, I think that what she wants is to communicate with her family, and I believe I can help." Sam took the phone, and in less than 2 minutes, Sam had this woman communicating with her sister and with her daughter, who came to help, came to be with her later. Listen, Roberto, listen. That is the primary thing we do as chaplains that I did not do at that time because I was too much into myself. I am the speaking chaplain. I am the one appropriate for this one. And well, while I was having that approach to the attending to this woman, Sam was quiet and listening, actively listening. I don't know if you have heard this before. I'm sure you have. Listen and silent and listen have the same letters. You know, God speaks in the silence. So, and which leads me to the second point, you know. And on one occasion, I was paged to provide spiritual and emotional and spiritual support to this woman who was very distressed. And I was there talking to her and listening. This time I was listening for a change. And while I was there, an NP and a physician came in the room, and without acknowledging my presence and without even saying, excuse me for interrupting to the patient, the doctor began to ask about medical stuff. How is that injury? How is your back? Do you have a headache? How is that stomach pain? The lady said, yes, I have pain, but the biggest pain is in my soul. And I could just saw the face of the physician. There's not much I can do about it. I was about to leave, and the doctor says, chaplain, I think this one is for you. I went back to talk to this, to continue the conversation with this woman, and she continued talking to me, and oh my God, I heard, you know, like, the most horrendous and pain that I ever had in years. She was really indeed a wounded soul, very, very wounded soul. And so, and moreover, she was feeling abandoned by God and angry and could not express that anger. So I was there. At some point, I was able to say to God, where are you? Where the heck are you? Are you deaf? And in that way, for me, saying that, giving her permission to express anger. And yes, sometimes we are there to be advocates, and even to be advocates to speak to God that way, that to let the person know that he or she can speak that way. You know, others listen, and they can listen in the same way that I do, but we do it from, chaplains do it from the perspective of our call. I am called to do this. I get it, my inspiration from the scriptures. I am a Christian, I'm Catholic, you know, after all. So I do it in the name of Jesus. When I forget many times, and sometimes it goes to my head, oh my God, I did so good, or oh my God, I didn't do very good. And I forget the most important thing. I am there to be the best instrument of God's compassion. I am there to be the best instrument of God's love. And that's what we are. They talk to us, and they talk about their soul being so wounded because they see us. We represent forgiveness. We represent God. We represent compassion. So I pray to be the best instrument of that compassion. Thank you.
Thank you, Roberto. Corinne, you're up.
That was lovely. Thank you, Roberto.
Welcome.
So I'm gonna talk about patient voice through a story. And I'm gonna tell a story of a near centenarian woman who was very healthy and loved life. She was in the Red Hat Society. She could walk. She gardened. She was connected with her church family. She never was married, didn't have children. She had a non-traditional, kind of a little bit different family dynamic where her main support was her niece. Her niece also had not been married, also did not have children. And these two were each other's support. They lived together and they laughed together, they cooked together, and they legitimately liked each other. They enjoyed each other's company. They had kind of a different kind of humor, and they had lots of friends that they stayed social with. Well, suddenly this woman, the patient, was found unresponsive on her living room floor. The niece called 911. Patient was brought to the ER and then was admitted into the hospital with a critical neurological event. She was placed on life support She was no longer able, she was nonverbal, and she was intubated and on all, was pretty much, was non-responsive. Well, what we found out, palliative care was called in because of her age and because of how critical the situation was. So we were called in. We wanted to take time and space, don't want to jump to any conclusions. We found her advance directive, we had that, and it said, I want all life-sustaining measures. Like, she literally went and wrote in this advance directive, do everything possible. I want to live, I love my life. So we honored that. We also looked into medical records, and we saw that she recently had a meeting with her primary care physician. The primary care physician had noted this patient wants to live. We're having this conversation. She loves her life. It was actually documented just days before this event that she loved her life. So we wanted to be, it was very sensitive. As we got to know the niece, we realized that, you know, there was going to be some complex grieving, some pre-bereavement, because this aunt, the patient, was really the niece's primary, her only connection, with a deep connection, because she, although they had fun social things in the community, this was her main love. And so we were very sensitive to that. The niece was the power of attorney for healthcare. So as we're walking along, honoring patient's voice, not making any rash decisions to do one thing or another, just seeing how things play out. There are lots of different specialties involved. There's neurology involved, nephrology, neurology. None of them are really giving a definitive answer about what we can really expect. So niece is holding on. You know, I'm going to advocate for my my aunt. I want to honor her last wish is to try everything. But, you know, we're really seeing, it's really hard not to see that this patient is declining. And over months, it's starting to show that the nurses are having a lot of moral distress as they go in, and they're kind of bathing and helping, doing ADLs for this patient who's really not getting better. And maybe the nephrologist would come in and say, oh, well, the numbers are a little better. You know, it's the truth, but the niece will grab onto anything saying, okay, wow, there's a chance. You know, we're starting to look at things maybe legally, you know, is this really ethical to keep someone alive? And there's not a definitive answer of if this patient's in a persistent vegetative state. That's a tricky thing to diagnose. But here it is, this niece who is patient's voice. The patient no longer can speak for herself, but the patient's voice is through her document, POA document. The patient's voice is through the PCP. The patient's voice is through the niece. You know, we're honoring this, but you know, how far do we take it, and how do we handle this moral distress of nurses who are really perceiving this as suffering? So I won't bring it to a conclusion, but just giving an example of patient voice when they're no longer able to speak for themselves.
Wow, thank you.
Mm-hmm.
Marty.
Well, that's a nice tie-in too, I think, from my final piece here. So that the question posed is really, how do I, as a physician, help to give patients a voice? And I would answer that question really differently today than when I was a fellow. I mean, in training, I was focused on being an advocate for patient autonomy. And palliative care has that role to play, but, and I think there's a big but there, and it's, what I didn't think about enough back then was, what are some of the pitfalls about palliative care advocating exclusively for patient's voice? So the opinion I want to share, I think, boils down really to three things. And number one is that over the last half century or so, medicine has really changed. And one of those changes is that you've got physician paternalism, which has swung all the way over sort of to the other extreme, kind of beyond patient autonomy, to where we are seeing at times patients dictating medical care. We all see this occasionally here in the hospital. And it's not uncommon, I think, to be consulted by a team who feels that maybe medical care for a particular patient is unreasonable in some way. They don't feel like they have a voice in the matter, especially, I think, in the intensive care units. So this brings me to point number two, which is provider burnout. And there's a lot of reasons for burnout, but one of them, in physicians in particular, is a loss of their own autonomy, sort of a loss in the ability to say what medical care should be or should not be delivered. And we've seen this too, especially when cases sort of inch closer towards futility. I had plenty of colleagues leave this hospital purely because of burnout. I think a lot of it stemmed from autonomy. And so how does palliative care fit into this is really my third and final point. You know, our specialty is often, I think, called into these distressing scenarios where there's conflict between the provider autonomy and patient autonomy, or provider voice and patient voice. And I think if we exclusively work to give patients a louder voice, we do risk at really eroding at that physician autonomy, worsening burnout. And so what I've been trying to advocate for more now is that whenever I hear the question, well, what is best for the patient? You hear that almost every day. That we're also asking the question, and what is also best for the medical team? Trying to take both into consideration, at least as much as we can. And so to come full circle, how do I, as a physician, help to give patients a voice? I would advocate that we in palliative care should really be working to give patients a voice while at the same time supporting the voice of our colleagues, which sounds so simple, but extraordinarily challenging to do in reality. And I'm trying to get better at that. And so that's my 2 cents.
Thank you, Martin.
Thank you all. It's a lot to take in and be with. We want to open it up for questions or thoughts. And so please, if anyone, feel free to unmute to show your face if you want.
I would like to say something too. I know I just spoke, but I would like to say, you know, there is the psychological burden for staff, absolutely. But I would consider the psychological burden for family as well, you know, of how that would have affected the niece had she given up too soonly, you know, too soonly, that's not a word, too quickly. How, you know, how that would have affected her long term if she hadn't had the opportunity to advocate for her aunt. So.
Martin, thank you very much. And that was a different perspective. I really like the way you put it. And I've seen that when sometimes I myself see families wanting to say, no, continue. I mean, no, comfort care, no, none of that. And we want to fight, and she's a fighter or he's a fighter, and just continue to the point that, oh my gosh, you know, how far do we go? And so when you do this presentation and ask those questions, you know, about the medical team, you know, wow. And you say, you know, also in addition to asking what is best for the patient, what is best for the medical team. Oh, hopefully, like in asking what is best for the patient, what is best for the patient also includes what is best for the medical team, you know, because you may see it and sometimes the family may not see it. Or I don't know, but you know, that's a great approach. Yeah.
Sometimes they're in conflict with each other.
Yeah.
Yet the medical team, right? The point of the medical team really is to advocate for what's best for the patient. Yet the patient might not be seeing what's best, right? Like you're really on the same page, but maybe not experiencing being on the same page.
Hi, this is Rose. I think you guys did an amazing job of giving very different perspectives, which I think, not to wrap it up in a little package, but it's like, this is all about walking in other people's shoes. And, you know, that can be, whether that's the patient, the loved one, or the medical team, everybody brings their own past, their own experiences, and all those things influence their perspective. And I think there's, you know, something special about palliative care that's really at the crux of what we do, is trying to walk in others' shoes. And it doesn't always feel good. And you're not always going to get the result that everyone collectively is hoping for. But it's then this kind of like risk benefit, right? If we go with what the patient wants, the medical team may have some suffering if they feel they have to revive someone that really they're you know, inflicting pain on. You know, that's difficult. It's the same when, you know, we have to tell a family that, I'm sorry, but we can't do this to you, to your loved one or for your loved one because of XYZ. So I think that really is like the bottom line for what we all do, is trying as hard as we can to walk in others' shoes and make sense of it.
Even within our own team, how different our own palliative care chaplain, social worker, physician, nurse, etc. feels about any particular case.
That's why I've always loved, so Peg McGonigal and I, who's also a chaplain, have done numerous visits together. And we both have had that, like, thank God you're here, you know, because you get this perspective that if it wasn't in the room with you,
Yeah.
you wouldn't consider. And it's so helpful to the patient.
That is the beauty of a multidisciplinary team, right? Different perspectives, different paradigms. Then it would be a dangerous place if there was only one perspective kind of running with it.
Yeah, sure. Sort of feeds into another one of my soapbox issues, unilateral decisions, because they're unilateral instead of more of a collaboration, but that's a topic for another day.
Martin.
Yeah.
Do you ever walk into a patient's room when a chaplain is there and you don't say anything, you just start asking questions? Never mind.
Oh,
No,
yeah.
you are a palliative care physician. You understand, you know.
That's a dangerous question, Roberto.
So I see Patrick might have something to say.
Well, actually, I'm glad I got a chance to chime in this morning or to tune in with you guys. It's been a really hectic several weeks here with COVID, just like you guys are being hit. And I think the other piece to this, and Martin, what you're saying really struck me, and I know, Corinne, we've talked about this last year, is in addition for us in our roles, whether it's chaplain, social worker, palliative care clinician, seeing patients in vulnerable moments, we also get to see our professional colleagues in vulnerable moments as well.
Yes.
Times when sometimes their mask is off, you can see the emotion they may feel. It can be the whole gamut. I've seen people in rage almost banging their heads on tables during telephone calls about futile situations. But yet yesterday I saw a really talented intensivist while we were on mute, thank God, saying, I hate myself. I hate myself for having to tell this family he's dying. And it turned out the other part of it was a daughter of the patient was a worker in another hospital where this intensivist works periodically. And I think maybe it's something about COVID with the widespread across the community that we're all getting exposed to people who typically normally maybe often wouldn't be in tricky health situations, suddenly exposed to that. And we're exposed to family and friends and other people who are sick, neighbors, et cetera. And there's another layer to that. But if it wasn't clear to me when I went into that call, it was clear when I left. I had another patient, which was this young clinician who needed, a bit of propping up and dusting off and, just sitting with for a bit. So there's a lot we're asked to do, and luckily we're, I think, the right people to do it.
Thank you, Patrick.
Roberto, I loved the statement you made about that listen and silent have the same letters. I had never heard that.
Really?
And
I didn't invent it.
I actually wrote both words out on my little Post-it note here and crossed out the letters. And I was like, oh my God, how did I never notice this before?
Yeah, it does not work in Spanish. It only works in English. But if you look at the world, the English-speaking world is so loud. It's just so talking to the world, and just English is the language. So yeah, maybe that God was so smart to do that,
You're saying God speaks English.
Yeah.
But and I think to Martin's point, like kind of taking that listen and silent. Make sure to be doing that to both patients, but also the other team members, and make sure that we are listening to their concerns and their thoughts as well, while still trying to honor the patient autonomy. But thank you for that. That's really struck me.
Thank you for emphasizing that, Katrina. There were a couple of comments in the chat I wanted to raise, and one was from Maureen that said, I think the beauty of the team approach is that we can support each other in these difficult cases, and intensivists often feel alone. So I also feel that part of our job is to support other providers. And Michelle just wanted to say, great job and very informative, and thank you. And Jennifer says that she wishes she had a team with her to lean on.
Not every palliative care team is huge out there. Some people are out on islands.
Mm-hmm. Yeah.
We're pretty lucky.
Well, thank you all. You've given us a lot to think about. Each one of you. I mean, Roberto, I think about your humility and being open to Sam and being able to share that story with us. Sam was a student at the time, so that's so thank you for sharing that. And Corinne, I can just feel the challenge of that experience with that family and patients. And Marty, thanks for excavating these mysteries and helping open us up.
Yeah. All right, guys. Well, have a wonderful Friday and an enjoyable weekend. Next week is Thanksgiving, so no chalk talk. So we'll see you in 2 weeks.
Thank you.
Thank you.
Bye.
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 Did you say you were waving for your